Hey, today I want to talk about glaucoma. Glaucoma is a disease of the optic nerve, and it is a category of diseases, more accurately, that all share the same general characteristics, which is a progressive thinning of the optic nerve tissue, often related to eye pressure within the eye, but not always. The way that we diagnose glaucoma is through kind of extensive testing and a thorough exam. It's not one single test that tells us that, yeah, you definitely have glaucoma. In fact, we might be able to rule out glaucoma entirely. We might be able to say, yeah, based on all these testing, it does seem like you have glaucoma, or you might be somewhere in the middle. Patients we call glaucoma suspects, patients who have, certain characteristics or family histories or some episodes of elevated pressures that tip our antennas that, hey, we should probably follow this patient and see if they develop glaucoma, but you don't quite meet the development and diagnostic criteria yet. Not quite today. Let's step back and think a little bit more about the anatomy of the eye, and then we can better understand what glaucoma is and ultimately how we diagnose it and treat it. So as I mentioned, glaucoma is a disease of the optic nerve, which is this structure right here. And for a general overview of how the eyeball works, I have a video that I've already made about the eye's anatomy. But the pressure is due to kind of a buildup of pressure within the fluids of the eye, kind of this general cavity here called the vitreous cavity, but more precisely, it's the very front of the eye. The tissues here called the ciliary body have little epithelial skin layers that produce fluid, and that fluid circulates around the natural lens, up through the pupil, and eventually out through the angle of the eye, which is basically this structure right here. Now, you actually can't see the structure on a typical eye exam, at least not usually. So we need special equipment and tools to evaluate that more precisely. So what happens if you have glaucoma? Well, the ganglion cells, which are the top layer of cells within the retinal tissue, in the nerve tissue itself, that layer is sensitive to pressure within the eye, and that can thin out. And we analyze that through a special type of test called an OCT that looks at the thickness of the ganglion cell layer. It then ultimately looks at the retinal nerve fiber layer, which is the first axons or the kind of offshoots of those ganglion cells that ultimately form the nerve itself, which is a collection of those axons. And the appearance of the nerve looks different for patients with glaucoma. So on exam, we can look and we can say, oh, this looks a little bit unusual. And we describe that oftentimes as an enlarged cup to disc ratio on the exam, which means that the outer perimeter rim of the nerve is defined, but the ratio between the central invagination of that nerve looks a little bit larger than it probably should in most patients. And that suggests that the pressure is almost pushing that nerve tissue out. It doesn't work exactly like that, but that is kind of how we think about it, and it's an easy way to understand it. There can also be certain notches or vascular patterns that suggest that the nerve looks suspicious for glaucoma, and that often will prompt a more thorough workup. Now, the OCT itself will actually measure the nerve fiber thickness and the ganglion cell in more modern OCTs, and that gives us kind of a heads up that, yeah, you do have some relative thinning compared to other people your age, and that's important to kind of look at and diagnose, and again, requires that additional test if our suspicion is high. So if the nerve tissue is damaged, what happens? Well, unfortunately, you often don't know that there's a problem until very late in the disease process, and that's because the symptoms of glaucoma are often none, at least for traditional open-angle glaucoma, which we'll talk about in a second. This is an example of why you should get your eyes examined routinely so that we can determine or we can assess whether or not you have some signs or patterns that are consistent with glaucoma. But for those who do have symptoms, it's often peripheral vision loss or the outer edge of your vision that starts to get cloudy or grayed out, or you feel like what you're actually seeing is circling in. And that's why very late in the disease process, it's really that central vision that's often spared, but mostly darkness in the periphery, which is really, really devastating. Glaucoma is called the silent thief of sight because it takes a long time for patients to really realize that there's a problem. And that's often because we have both eyes. So if you have a deficit on one eye, the other eye can fill in some of those gaps until, again, very late in the disease process. And it's not uncommon that glaucoma affects each eye differently or slightly asymmetrically, so one eye can develop more aggressively than the other. We also have to look at the functional loss of the nerve tissue, and that can be done with a computerized test called a Humphrey visual field or equivalent testing depending on the brand, and it will look at a pattern of brightness levels of little flickers of light that will come off and on, and you will click a button when you sense that light. And this is important that you look straight at the center during the test so that your eyes aren't darting around. But assuming you're looking straight ahead and your peripheral vision suggests that there is a pattern, consistent with visual field loss, that is another checkbox to suggest that you might have glaucoma. And we'll talk more deeply in other videos about what patterns we look for on a more advanced level. But just suffice to say that if the visual field looks a certain way, then the doctor might say, yes, this looks characteristic or specific for glaucoma. There are a lot of other patterns of visual field loss and damage that suggest other pathology, like strokes or brain tumors, for example, that would present differently. A normal ocular pressure is somewhere between 10 and 21 millimeters of mercury. That's dependent on the corneal thickness, which is another part of the glaucoma exam, and that's done basically by 3 different ways in modern eye practices. The first is with a Goldman tonometer, and that's that little kind of device that gets very close to the eye, and that requires anesthetic, so we usually give a drop of proparacaine or tetracaine before we do a Goldman applanation. And based on the pressure of the eye, the applanator will basically touch the cornea and depress the cornea. So the higher the pressure within the eye pushing back against that probe means that more pressure is needed on the dial to create that dimpling within the cornea. And that will tell the doctor what your pressure is based on how much force is needed to achieve that result. It's a very reliable test and pretty much the gold standard for when it comes to pressure. We don't really use air puffs so much anymore. The other way that we can test pressure is with a tono pen. This often requires an anesthetic as well, but it doesn't use that blue or green dye the way a Goldman applanator does. But this basically will gently touch the front of the eye several times and give us a reading of pressure. I find it to be a little bit less reliable than the Goldman, but really helpful again if you're on the go. And the last method is called a rebound tonometer. This is a newer device made by Eye Care and Reichert that basically uses a tiny little probe that will flick in and out. It's so gentle on the eye that you really don't need topical anesthetic, and again, based on the force of the rebound of that little probe shooting in and out, again, very gently, it will give us a reliable pressure. And again, really helpful in on-call environments or if you're traveling, because you don't need all the expensive equipment of a slit lamp to check someone's pressure. Now, based on your pressure, which again can change throughout the day, based on your corneal thickness, based on your visual field pattern, based on your optic nerve appearance on a dilated fundus exam, and based on the nerve thickness as measured by OCT, doctors can take a look at all this data and say, yeah, it looks like you might have glaucoma. Now, if you do have glaucoma, there are a variety of treatments, and it depends on the different type of glaucoma, which again, we'll talk about in other videos. But I just want to talk about an overview of what glaucoma is and how it's diagnosed, so that if the doctor says, hey, we are concerned about this problem, I want you to be aware of what it is that we're actually talking about. So if you have any questions, or if you actually have glaucoma, feel free to comment below about your experience with the disease and how you have been managed. Thanks again for your time, and I will see you in the next video.